old crowns, old bridges, old fillings, consider replacing restorative. And we often just like wait because, it was a tougher thing to do. But what's the trade-off? The trade-off could be long-term periodontal health.
What's up, dental peeps? It's your girl Irene here with Tooth or Dare podcast. Hold on to your suction. It's about to get slippery.
Are you tired of feeling like a contortionist after a long day working in clinical practice? This message is brought to you by our sponsors at Designs for Vision, who are offering you a 45-day free trial of any of their loupes. But I strongly encourage you to try their ergonomic loupes called Infinity View. Say goodbye to your chin down, neck cranked, poor posture, dental procedure and practice. All you have to do is go to their website, submit a form in order to get your rep to reach out to you, get measured, and get your loupes. And then you get 45 days to figure out if you like them or if there's anything that you want to change. Or you can just send them back. But I don't think you will. So buckle up, get ready to rock the Infinity View loupes and say hello to a life filled with joy, comfort, and amazing posture. Thank you, Designs for Vision, for creating these beautiful loupes. I can't go back to my old ones. Ever.
Welcome back to another episode of the Tooth or Dare podcast, peeps, with your peep Irene and the lovely
Beck.
Bachelor's Honors Dental Hygiene, Beck.
Is that how you're going to introduce me now?
I don't know. I think it's just a Russian roulette at this point. It's going to be a different intro every time. We are back answering clinical questions from the pin post on my Instagram.
Yes.
Which is where we've been getting inspiration for all of our episodes because we want to give the people what the people want.
Yeah.
And it sounds like the people want more of this and less of the other stuff. So
there's some really great questions.
So today's focus is on one from Joyzy.
I feel like every episode we get a different
version of Irene.
Yeah, a different impression.
Personalities. Today's question is on, read it out. Let's do it.
Okay. A patient has bone loss. Are we sure it's from periodontal disease? Could it be from other factors, occlusion, ortho, more than one factor?
Let's answer together. 1, 2, 3.
Yes. Absolutely.
I think she answered it herself. I think she was typing it out, and by the end of it, she was like, "Oh, and this, and this, and this." It's like, send.
Yeah.
The answer is yes.
Yeah.
I think that I see more occlusal related recession and bone loss localized than I see true periodontal disease.
I agree.
I think it's such a significant contributing factor. Okay, so let's list them out.
Okay.
So reasons why someone would have recession and bone loss. Occlusion being one of them.
Yeah. Ortho.
Needing aligner therapy or orthodontics. Certain medications like medication-induced bone loss. Mouth breathing, like the drying of the mouth, mouth breathing cause. And we can break down each one of these a little bit further. Let's just talk about occlusion. Okay. So when teeth don't fit together, certain things fall apart, hard tissue and soft tissue. And oftentimes when we see patients that have narrow arches, and interestingly enough, we did our Spear Study Club at the office this week, and the course that we watched delivered by Dr. Frank Spear was about the connection between malocclusion, airway, and aesthetic problems. Hey, you watched it too.
I did.
Yeah, you did. Okay. Because you helped me draft that copy. So perfect timing.
Yeah.
So looking at certain principles regularly, like the occlusal arch and the occlusal arch width being somewhere between 37 millimeters and 39 millimeters, measuring from the lingual cusp of the maxillary or first molars, can identify if in fact we have proper arch width. And if we don't, then what we end up seeing is more of a lingually inclined arch, where those molars are not vertical and centered in the alveolus, but they're leaning in, so they're taking up more space. But then you're starting to get like this crown to lingual and roots to buccal, thin biotype, less bone on the buccal surface. So you end up getting perhaps even less buccal bone. And when things don't fit together properly, like occlusally, upper molar, lower molar, or all teeth, then they're like banging into one another. And it has nothing to do with dentistry and like everything to do with physics. Imagine if you were like hammering a nail on the top of the the flat part of the nail versus on the side of the nail. And then the nail bends in the opposite direction. So we get these like improper occlusal forces leading to excessive vibration in one particular direction that leads to the deterioration of bone. So you may have a probing depth that just like drops in at one point. We've all seen that before, like a lower molar, they're missing their first molar, they've got their second molar space, the molar starts to lean in, and then you get this like vertical defect on the mesial. So I'd like to assume, I think personally, I see more of that than true periodontal disease.
Yeah. I remember I had this patient and he was like, my bite just really feels off and it feels like I'm hitting somewhere first, blah, 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 all the classic symptoms of a traumatic occlusion. And I'm like, okay, well, let's get out the paper and bite on it and, the whole 9 yards. And I said to the dentist, I was like, I'm pretty sure, something is off with a filling that was just done. I forget the details, but he's like, oh no, that bite's fine. I was like, okay. Sure. But
the patient could feel
yes,
it.
exactly. Yeah. And you're not the one living with that every day, like having even a slight 1 millimeter difference can really hurt.
Than a millimeter. I mean, like if you're taking shim stock. So let's talk about anterior constriction. So if you're taking articulating paper, and various articulating papers, there's different thicknesses of them. Some offices have a variety of thicknesses. We've got like 4 or 5 different thicknesses because we do prostho. Most dental offices will have 2 types. They'll have like the horseshoe for night guards or full arch checks. And then the standard 12 micron to 20 microns, like it depending on how thick and thin you have it. But if you're using shim stock, which is 8 microns, it doesn't leave a mark on the tooth. It's like a little teeny tiny piece of tinfoil. We talk about it a lot in our implant lecture.
Yeah.
Like that's the thickness of 3 or 4 hairs. Like if you were to take a few of your hairs, I don't even know how many this is, but we should look at it under a microscope. Actually,
we should
compare how many hairs is. But
I feel like it's less than that.
Less than that.
Yeah.
It's much less than that. I need a haircut. Jeez. The teeth are quite sensitive.
Absolutely. Yeah.
And another interesting thing that happens when you're in traumatic occlusion is that the teeth never really get an opportunity to be at rest. And that often means that they're forced up into the periodontal ligament and everything is just much more constricted.
Or you start grinding because you're trying to find your proper. Yeah.
Most people, I mean, there's a variety of different reasons why people grind. We could do a whole episode of that. But most people end up having clenching and grinding symptoms because of that occlusion, because their teeth are just trying to find the right spot.
Yeah.
Parafunctionally.
Or airway issues.
That too. Yeah. So when we look at anterior constriction, so every new patient gets a scan. And when we do our 3D scan, we use the heat map to identify where someone is in traumatic occlusion. Our goal is that no one is in the red or in the yellow or in the orange. Most people are in the green. But on the anterior teeth, we want people to be in the blue, meaning there's passive occlusion, but not functional, not functional occlusion in speaking and everyday movement. And we believe in canine guidance here. So like the first point of contact should be the canines. So if you were to take a piece of shim stock and slide it from in front of someone's mouth and from through their front teeth, like that piece of shim stock should hold slightly, but slide out without fraying or breaking. If you were to use a piece of articulating paper, it might still hold because it's thicker.
Exactly. Yeah.
So we end up seeing lower recession, like gingival recession, especially on the lingual. If you ever see lingual recession, that's that's telltale sign for traumatic occlusion.
Yeah.
So to answer her question, most of your patients probably have more occlusal related periodontal dysfunction, occlusal dysfunction leading to periodontal symptoms than in fact true periodontitis.
Absolutely.
So it's definitely a multifactorial approach. And then restorative. I see a lot of old restorative done. Old crowns, old bridges, old fillings that are, margins aren't looking so hot or they've shrunk. Like we get, shrinkage.
There's no anatomy put into them. It's just
teeth are just sliding around. And then you, or
Mhm.
like really some, and I do some of these fillings myself, so I can see how difficult they are to gain access.
Absolutely.
Like you're doing a subgingival box and marginal elevation. It's deep. So it's hard to isolate. Like I get it. Like
Absolutely.
sometimes you can't get the best result, even with all the right tools. But consider replacing restorative. And we often just like wait because, it was a tougher thing to do. But what's the trade-off? The trade-off could be long-term periodontal health. So do you want to lose a tooth because of disease, or do you want to lose a tooth because perhaps you need to do a different restoration that's not covered by insurance?
Yeah, I agree. So let's talk about what ways we can determine if it's true perio or if it's occlusion.
Do we need a checklist?
Yeah.
Sounds like we need a resource.
We're making a checklist on the fly.
Yeah. Okay. So first of all, like signs and symptoms. So doing your intraoral, extraoral evaluation. Do you see patterns of wear? Do you have loss of occlusion? Do you have wear facets on the occlusal surfaces? Do you see abfraction lesions?
Yes.
If you see a true abfraction lesion, so like pizza slice out of the sides of the tooth, you take your Explorer, your probe, and you physically feel an indentation. Yeah. What does the physical tooth end up looking like? Is it also, like what does the tissue look like? Is the biotype thin around that area? Because tissue doesn't like that type of force or friction as well. So evaluating the tooth. If you see occlusal wear, if you see abfraction lesions, if you see pitting in the occlusal, like wear facets, then it's pretty easy to tell that there's some parafunctional. Now, and then you need to determine whether it's active or inactive.
Yeah.
But most of the time, that doesn't stop on its own. And putting someone in a splint or a night guard or an Essex retainer doesn't stop the problem. It just kind of gives it a bit of a Band-Aid solution.
Pretty much, yeah. And then you can do DNA testing in the pockets and
oral DNA testing, bacterial testing. But that's only if you notice that the tooth looks normal. If the tooth looks normal, and then take articulating paper. Most molars have 3 to 4 points of contact. So ideally, anatomically, and I should have pulled our textbook for this, but ideally and anatomically, the cusp to groove ratio on an upper molar are supposed to interdigitate like a puzzle piece. So if you were to hold your knuckles together and put your knuckles together, for every one knuckle, you should have another knuckle that fits inside of the groove between the next two. So for example, on the upper, if you have your distal buccal cusp, it's supposed to fit into the groove and the cusp of the lower molar in class 1 occlusion. Some people are in functional class 2 and functional class 3, so they've worn their teeth down in order to make that happen. But generally speaking, if you were to take a photo of someone with their teeth biting together, it should look like 2 mountains fitting into 2 valleys. Yeah. If you don't see that, then likely you have parafunctional habits that are leading to malocclusion, which are leading to symptoms of periodontitis.
Yeah. And then it gets tricky when you have things like crowns and implants.
Right.
That's a whole other.
But they should still technically be built the same. And if one person's upper arch has some prostho, but the lower doesn't, like you should still be able to take that photo and trace over top. And ideally you're working with a lab that understands occlusion.
Yeah. I feel like there's this trend that's happening where they take, like now you're taking prostheses out of occlusion completely.
Right.
But
I see that for implants.
Yeah.
I see that a lot for implants.
And I get it. You don't want the torque and the forces on it, but that can cause other issues.
Sure.
Depending on where it is and the placement.
Yeah.
But
yeah.
Whole other topic. Whole other topic.
Implant topic is one of my favorite things. No, it's great. It's really good. I think it's important. Bottom line is that without a really great evaluation, without good photos, and without some sort of like, there's a device on the market now that I think I sent you. Yeah. It kind of looks like one of those glow whitening
or
things.
shoe. Yeah.
You're supposed to bite down on it, and then it connects to a computer and it demonstrates the force that's applied to each tooth and in which path.
Mm-hmm.
I think that's so valuable.
It's very cool. Yeah.
I want to get one of those. But
Yeah.
I want to get everything.
You want everything.
I literally am buying everything. Just take my money. I think that that's really valuable because how are you really supposed to assess what's happening if you don't have like proper metrics to support it?
Yeah.
But
yeah. Agreed.
Yeah.
Yeah.
So that's that question.
Yeah, that's the question.
Other part of it. So she asked about ortho. What else did she ask about?
That was it.
Any other reasons?
You hit them all.
We did it.
Yeah.
We did it. Amazing. Great. Okay. Well, that's it. Ask your questions on our pinned post, comment, and until next time, peace out, peeps.
Bye.